Hello and welcome back to the Pituitary Lecture series. So this is the 8th lecture, and today we will be discussing about pituitary tumors. My name is Dr. Santosh Abraham. I'm working as a specialist registrar in diabetes and endocrinology at Carbagon Hospital. So let's start. Briefly, the contents will be pituitary tumors, the general characteristics. Even though about the genetics I have previously explained in detail in acromegaly, so it might be worth watching that video too if you want to know more about the genetics of pituitary tumors. Prolactinomas, non-functioning adenomas, Thyrotrophinomas, Craniopharyngiomas, pituitary carcinomas, and pituitary mets. This is how we will divide today's presentation. Pituitary tumors. Adenomas are the most common, and they constitute 10 to 15% of primary brain tumors. 10% of the individuals harbor incidental tumors, so they are mostly microadenomas. Incidence of clinically noticeable disease is 1 in 10,000. Carcinoma of the pituitary is very rare. It's less than 0.1% of all the tumors. Most commonly it is ACTH or prolactin secreting. The approximate relative frequencies of pituitary tumors are shown in this table. Overt pituitary tumor adenomas are the most common. So they are clinically overt. It is followed by acromegaly. It is followed by non-functioning adenomas and then acromegaly. It is followed by prolactinomas, non-functioning adenomas, and then acromegaly. So clinically overt pituitary adenomas are the most common, followed by prolactinomas, non-functioning adenomas, and acromegaly. The incidence differs, however. Classification is, if you have a tumor less than 1 centimeter, it is a microadenoma. It's more than 1 centimeter, it's a macroadenoma. Prolactinomas are most common, 40%. Non-functioning are between 30 to 35%, followed by acromegaly, growth hormone secreting tumors, 10 to 15%. This is the normal MRI of a pituitary. So you can see the pituitary here, it's quite normal here. You could again see the pituitary here. So it's arising from the straw. You can see that here. So when you have a pituitary adenoma, it looks like this. What is the importance of pituitary disease? It is associated with an increased mortality, predominantly due to vascular disease. It could be due to oversecretion of GH or ACTH, and the hormone deficiencies or excessive replacement following that. Radiotherapy is also associated with increased mortality, mainly cerebrovascular. Craniopharyngiomas patients also have increased mortality. I'm sorry for the clarity of this slide, but this is the molecular mechanism of tumor pathogenesis in pituitary. So the most important ones is the activation of the oncogenes. Among that, GS alpha mutations are the most important. It is found in 40% GH secreting adenomas. RAS mutations are found in aggressive tumors. And PTTG has been recently been described, and it is overexpressed in certain pituitary tumors. So the activation of oncogenes involves GS alpha, RAS, and pituitary tumor transforming gene (PTTG). Inactivation of certain tumor suppressor genes like MEN1 or retinoblastoma could also lead to pituitary tumors. Cyclins and modulators of cyclin activity, their mutations, especially in CDK P27 and P18, are found in human pituitary tumors. So P16 could be silenced by methylation, and P27 could be translationally downregulated. The problem with all these is cyclin D1 overexpression, and it is an early step. These mutations are rare in pituitary tumors. So the most important ones are the activation of oncogenes and inactivation of tumor suppressor genes. It could be also due to alterations in receptor and growth factor expression. This slide shows genetic alterations in pituitary tumors. As I've already told you before, the GNAS mutations are the most important ones. They are commonly associated with adenomas, and it's an activating mutation. It constantly activates GS alpha, leads to upregulation of intracellular cyclic AMP. So protein kinase A, germline inactivating mutations of PRKR1A, usually found with Carney complex, are found in GH and prolactin adenomas. So loss of PKR regulation leads to inappropriate cyclic AMP. Cyclin D1, which is rare but is overexpressed in certain aggressive adenomas, and it promotes G1S transition. That is the phase in cell cycle. And finally HRAS. So it's again an activating mutation, and it is associated with pituitary carcinomas. So it has got multiple pathways, including proliferation, survival, and metabolism. So in short, GNAS, protein kinase A, cyclin D1, and HRAS are gain of function mutations. Loss of function mutations are MEN1, P27, KIP1, AIP, and RB. So MEN1 is found with MEN1 tumors, and the pituitary tumors commonly associated may be a GH secreting or prolactin or ACTH secreting adenomas. So as you all know, it encodes for the menin gene, and it's a tumor suppressor gene. So loss of function will lead to repression of the oncogenic TFGN and in histone modification. Coming to the CDKN1B or the P27K1P1, it is associated with ACTH adenomas. That is very important. Again, there is inactivating mutation from the germline, and what about the AIP? So the germline mutations of AIP cause pituitary adenoma predisposition syndrome, or called PAP syndrome, and it commonly results in GH adenomas, and they're common in younger patients. Finally, retinoblastoma, when it's methylated at the RBG promoter, it could result in aggressive adenomas. So if I am to summarize, let me start with the aggressive adenomas, which are easier for you to remember. So aggressive adenomas are associated with cyclin D1 and retinoblastoma. ACTH adenomas are associated with CDKN1B. GH adenomas are usually associated with GNAS, so that is very important. PRKAR1 alpha and AIP. AIP mutations in patients less than 35 years of age. MEN1 generally is associated with a variety of adenomas like GH secreting prolactin or ACTH. Prolactinomas are the commonest functioning pituitary tumors. Macroadenomas are present in 10% of the population. Microprolactinomas are commoner than macros, and there is a female preponderance of microprolactinomas. The pathogenesis is unknown. Prolactinomas are the most common pituitary tumor in MEN1, and they may be more aggressive. Malignant prolactinomas are very rare, and if you have a malignant prolactinoma, they might have a RAS mutation as well. So the clinical features are up to 90% of the females show galacturia, up to 95% show menstrual disturbance. In males, it could be associated with loss of libido or erectile dysfunction, but reduced fertility and oligospermia or gynecomastia is unusual. Increased prolactin is associated with long risk of decreased bone mineral density and hence osteoporosis. These are the causes of hyperprolactinemia. You have physiological causes here due to a pituitary tumor, due to hypothalamic disease, due to infiltration, due to stalk section, radiotherapy, or drug treatments. So physiological causes are usually pregnancy, sexual intercourse, nipple stimulation, neonatal, or stress. Tumors of the pituitary like prolactinomas, mixed tumors, macroadenomas compressing the stalk or empty cellus. Hypothalamic disease, here the most important phenomenon is stalk compression, infiltration in the form of sarcoidosis, histiocytosis, stalk section when it happens with head injury or surgery, radiotherapy, drugs like dopamine agonists, neuroleptics, antidepressants, and there are a variety of drugs. Investigations, you will start with a serum prolactin. If it is less than 2000 milliunits per liter, it is suggestive of microprolactinoma or a non-functioning macroadenoma. If it is more than 4000, it is diagnostic of a macroprolactinoma. So the non-functioning macroadenoma could be due to the stalk compression. You need to exclude the hook effect. So I have told you that in the discussion of hyperprolactinemia, in another video, hyperprolactinemia and guidelines from the Endocrine Society. You should also not forget that hypothyroidism and CKD can cause hyperprolactinemia. Imaging, microadenomas usually appear as hypointense lesions on T1 weighted images. Macroadenomas are space occupying tumors. They could be associated with erosions or cavernous sinus invasion. Treatment, for microprolactinomas, the aim is to restore gonadal function. For macroprolactinomas, again, aim is to restore gonadal function with the reduction in tumor size and prevention of tumor expansion. How do you restore the gonadal function? It is by lowering the prolactin levels, ensuring adequate sex hormone replacement. Is an alternative. Macroprolactinomas, the risk is expansion and pressure effects. So definitive treatment is surgery. dopamine agonist, it will lead to the suppression of prolactinoma in most cases, but if it doesn't help in the shrinkage, you will go for a surgery. So for any tumors, pituitary tumors, you need to check for the prolactin, and for prolactinomas you try the DAs, and if it is not shrinked with the DAs, you go for the surgery. When you treat with PRLs, PRL agonists, with dopamine agonists, the PRL will get suppressed and there will be normalization of gonadal function. So the shrinkage of the tumor occurs at a variable rate in 6 to 12 months. When you are trying this dopamine agonist, there will be slow chiasmal decompression, and it will gradually correct the visual field defect in majority of the patients. Hence, there is no immediate surgical decompression needed. But if there is no improvement of the visual fields, despite the shrinking of tumor, it indicates that even if you do the surgery, improvement is less likely. And other hormonal axes will become better with the tumor shrinkage. Among the dopamine agonists, Carbagon is more effective than bromocriptine. It has got fewer side effects. Carbagon in higher doses used for PD is known to cause cardiac fibrosis. But in prolactinomas, you use lower doses. So there is no evidence of cardiac fibrosis occurring in the treatment of prolactinomas. DA resistance occurs when there are reduced number of D2 receptors. Tumor enlargement following initial shrinkage on treatment could be due to non-compliance, or it could be suspicious of a carcinoma. Carbagon and cardiac valvulopathy. Carbagon is a 5-H2B receptor agonist, and high doses, 3 mg per day more than 6 months in PD, are associated with valvular heart disease like aortic, mitral, and tricuspid regurgitations, as it targets 5-H2B. But this risk is low in prolactinoma because the dose is less than 2 mg per week. So if you are putting your patient under higher doses, annual clinical cardiac examinations are needed, and probably you might need to do a periodic echo. Coming to DA resistance, it is defined as the failure to normalize prolactin and the failure to decrease tumor size to less than 50%. It occurs in 24% with bromocriptine, but the DA resistance is less with Carbagon. The mechanism is that the receptors are reduced in number, but the efficacy is the same. Options are including the switching DA, increasing the DA dose, surgery, fertility treatment or estrogen replacement, or even radiotherapy for macroadenoma. Surgery is indicated only for patients who are resistant to or who are intolerant of DA treatment. With surgery, the cure rate is very poor for macroadenoma. So the drug treatment is first line in tumors of all size. This is in contrast to other pituitary tumors where you do the surgery in most of the cases. Surgery could also be done when there is a CSF leak in an invasive macroadenoma. The surgical cure rate for microcarcinoma are more than 80%. But you need to consider the risk of hyperpituitarism and the recurrence. So this is a second line option here too. Bromocriptine could result in increased tumor fibrosis. Radiotherapy leads to slow reduction of the prolactin in majority of the patients. If you are on radiotherapy and if you want it to be effective, since it's very slow, DA therapy should be continued and it should be slowly withdrawn on a biannual basis. Non-functioning pituitary adenomas or Nfas, they are unassociated with clinical syndromes of anterior pituitary hormone excess usually because they are non-functioning. They are the most common pituitary macroadenoma, represent 28% of all the pituitary tumors. Majority of the cases are found in above 50 years, 50% enlarge. Even though Nfas don't produce hormone, they may stain for glycoprotein hormones or ACTH, or may be negative on immunostaining. Some of the tumors will be slow growing, while others could be aggressive too, and others could locally invade the sphenoid and the cavernous sinus. If you have this marker K167, more than 3%, it could indicate a potential marker, a potential chance for the tumor becoming aggressive. So in an NFA, the primary investigation is pituitary imaging. It will demonstrate the size and the invasion into cavernous sinus or supraoptic recess. You need to do a visual field assessment. It could be abnormal in up to 2/3 of cases. Very essential, do the prolactin. So if it is a prolactin secreting macroadenoma, you will go for the DA agonist therapy. You need to bear in mind that mild elevation, usually around 2000 mu per liter, could be secondary to stalk compression. Assess for pituitary function for any features of hyperpituitarism. In short, you do a pituitary imaging, usually with MRI. You assess the visual fields, you measure the serum prolactin, and you assess the pituitary function to know whether you have any, to know whether your patient has got any features or any biochemical evidence of hyperpituitarism. Can we predict the regrowth of non-functioning adenomas? Could be suspicious of aggressive behavior in younger patients, those who had cavernous sinus invasion, and after the surgery if you have a supracellular extension. Atypical features on histology like elevated mitotic index, MIB1 label index more than 3%, and macronucleoli all could predict a regrowth of non-functioning adenomas. Are there any biochemical markers for NFAs? No. Minority of the patients may have elevated FSH or LH levels, but the answer is no. Management. The management is definitely surgical. It removes mass effects. Partial recovery of the pituitary function occurs in 10%. Transsphenoidal is the route chosen. You need to closely follow up with pituitary imaging and visual field assessment to know if there is any residual tumor growing. Postoperative radiotherapy is controversial, but it has shown to reduce a regrowth rate to less than 10%. Medical therapy is usually unhelpful. Sometimes octreotide and other somatostatin analogs could be used. If the patient becomes hypopit, you need to replace the hormones, and the visual defects may improve after the surgery. So how do you image a person who has undergone a pituitary surgery for an NFA? You image in the first 3 months following surgery, then re-image annually for 5 years. After the 5 years, you re-image biannually, because tumor recurrence has been reported up to 15 years. So following the surgery, in the first 3 months, then every year for 5 years, then once in 2 years thereafter. How much you have the tumor remaining after the surgery will predict the recurrence risk. So if you have an empty cell, the 10-year recurrence risk is around 6%. Whereas if you have an extracellular remnant, the recurrence risk is 90%. DA may decrease recurrences, but there are no studies at the moment. NFAs have generally good prognosis when the diagnosis and appropriate treatment is done, including replacement of hormone deficiency. The main concern here is the risk of tumor regrowth with subsequent visual failure. So this is a slide which shows post-op assessment of NFA. After the surgery, immediately look for cortisol. If there is adrenal insufficiency, you replace. After 6 weeks, you look for the pituitary function, including the anterior and posterior pituitary functions if needed, replacements as needed. MRI pituitary in the first 3 months. Could consider radiotherapy. Yearly MRI till 5 years. Then once in 2 years. Prognosis. Good prognosis once you have the diagnosis and appropriate treatment. Radiotherapy could significantly reduce the recurrence of tumor. So radiotherapy is a potential option to decrease the rate of tumor regrowth. Hence, in non-irradiated patients, they require very close follow-up because the tumor can regrow, and if it regrows, you need to perform a repeat surgery or administer radiotherapy. Coming to Thyrotrophinomas, very rare, 1% of all the pituitary tumors. You have an unsuppressed TSH here in the presence of elevated free thyroid hormone. They're equally common in males and females. 5% have an association with MEN1. They found to be mostly macroadenomas, about 90%, and secrete only TSH. Here the features of hyperthyroidism are present but often are milder. Other complications like visual field defects and hypopituitarism due to the mass effect can happen. Investigations. TSH, most important, it is inappropriately normal or elevated, as that is what it differentiates from the primary hyperthyroidism, where it is really elevated. And in primary hyperthyroidism, where it is really suppressed, here the TSH is inappropriately normal or elevated. When you say inappropriately normal, when you have a raised FT4, you expect the TSH to get suppressed. It doesn't happen here. And it's a wide range. You can have the TSH between 1 to 568. and no correlation between the TSH and FT4. Hence, you have an inappropriately normal or elevated TSH. T3 and T4 elevated in only 65% of the patients. But you have the alpha subunit raised in 65%. You measure an alpha subunit to TSH ratio, molar ratio, and it will be more than 1 in 81%. So this is an important distinctive feature of TSHoma. Another important test is an absent response to the TRH test. It differentiates TSH secreting tumors from thyroid hormone resistance. In thyroid hormone resistance, if you do the TRH test, the TSH response is normal or exaggerated, whereas here in TSHoma, the TSH response is absent. Plus, you have an increased alpha subunit to TSH molar ratio, more than 1. You may have prolactin and GH occasionally elevated in mixed tumors, and SHBG could be elevated to the hypothyroid range. MRI will demonstrate a pituitary tumor in majority of the cases, 90%. What are the causes of an elevated FT4 in an inappropriately suppressed TSH or normal TSH? So they could be TSH secreting tumor, thyroid hormone resistance, amiodarone treatment, or inherited abnormalities of thyroid binding proteins. So I've told you the difference, how to differentiate between TSH secreting tumor and thyroid hormone in the former slide. Coming to craniopharyngiomas, I won't be giving any presentation on pericellular cysts, as they are rare and you need to read the books for that. I'll be mostly focusing on craniopharyngiomas. Very rare, could be associated with any age, decreased survival, that is the most important thing. It's got a bad prognosis. And pathology, it could arise from squamous epithelial remnants of the craniopharyngeal duct. It could be an adamantinoma or a squamous papillary form. There will be cyst formation and calcification in some of the cases. Usually a benign tumor, but infiltrates surrounding the structures and hence causes too much of bad effects. Well, you see raised intracranial pressure, visual disturbances, hypothalamo-pituitary disturbance, precocious puberty and growth failure in kids, and anterior and posterior pituitary failure including insipidus, weight gain. Investigations, MRI is the most important test. CT will help you to evaluate bone erosions. Definitely they need a visual field assessment and anterior and posterior pituitary assessments. Total removal is the aim, transfrontal or transpinoidal route. If it is not possible, go for the adjuvant radiotherapy. Trying to restore the pituitary hormone deficiencies is extremely unlikely. For cystic lesions, you could try aspiration alone, and along with the radiotherapy, it could reduce the likelihood of reaccumulation if you cannot do the gross tumor removal. You can see a craniopharyngioma here with the cystic and the solid components here. There's another MRI of the same. The management in general for the craniopharyngioma is shown in this flow chart. So if the tumor causes signs, do an imaging. If it is cystic, aspirate, try to aspirate, and then go for a surgery if it doesn't help. But if it is mixed or solid, you go for the surgery. In the surgery, you aim for the gross tumor removal, and if there is recurrence, look for any pressure effects. If there are no pressure effects, go for radiotherapy and then again check for the recurrence. If there is, you could go for individualized therapy like gamma knife radiosurgery or cyst controlling procedures. But after the gross tumor removal, if there is tumor recurrence and if there are acute pressure effects, again you have to do a surgery with radiotherapy and then look up for the recurrence. If after the surgery there is residual tissue, that is, you couldn't remove the whole tumor, you should give adjuvant radiotherapy and look for recurrence. How about tumors who don't show much features or signs? So again, you do the imaging, look whether it's predominantly cystic or solid. So if it is cystic predominantly, you do aspiration plus biopsy with radiotherapy. If it is mixed or solid, you do biopsy and radiotherapy. Look for recurrence. If it is again recurring, do the salvage surgery. If again it's recurring, you give the individualized therapy as I've told you before. And finally, if you cannot help with any of these, you try for the systemic chemotherapy. Rathke's cleft cyst, they are derived from the remnants of Rathke's pouch. So this pouch is lined by epithelial cells. It could be ciliated cuboidal, columnar epithelium, and it is usually filled with fluid. It's usually asymptomatic, may present with some minor headaches or amenorrhea. Rarely, it could present with hypopituitarism and hydrocephalus. So CT and MRI will show variable enhancement in this cyst. If symptomatic, you need to decompress. And recurrence is not as rare as originally thought. So you can see a Rathke's cleft cyst here in this MRI. Pituitary carcinoma. It is a primary adenophyseal neoplasm with craniospinal or distant systematic mets. That is the definition. So it's a primary adenohypophyseal neoplasm. Extremely rare tumors. Likely to demonstrate p53 positivity and have an increased mitotic index if it is a carcinoma. But the problem with histology is that it is unable to distinguish between benign, invasive adenomas and carcinomas. The etiology is the adenoma-carcinoma sequence in ACTH secreting tumors. Pituitary adenoma causing Cushing's disease, and followed by locally invasive adenoma leading to pituitary carcinoma. So you have an adenoma, so you have a adenoma here which will either secrete ACTH or a pituitary adenoma causing Cushing's disease, which will become locally invasive and then lead to a pituitary carcinoma. Even though the etiology is unknown, this is the assumed etiology. There could be metastatic spread, lymphatics and through the vascular routes, as well as local invasion and tumor seeding. Almost all of them are macroadenomas. There's a tendency to spread to the for a systemic spread to liver, lymph nodes, lungs and bones rather than the craniospinal spinal mets. So the systemic mets is more common here. So these are the types of pituitary carcinoma. You have the prolactin secreting and the non-functioning of equal proportion. But many non-functioning carcinomas were reported to be subsequently found to have prolactin secreting. So the true incidence of the prolactin adenoma producing carcinomas may be higher. So most of the pituitary carcinomas are assumed to be prolactin secreting, followed by the ACTH and the GH. Pituitary mets, it's very rare, equal sex distribution. Diabetes insipidus occurs in almost 100%. Very difficult to differentiate neuroradiologically from other mass lesions. Histology is definitely required to confirm, and the prognosis is very bad, and the surgical treatment wherever possible, or else with radiotherapy. These are the primary tumors associated with pituitary mets. Most important are the breast and lung, followed by others. Breast and lung accounts for 2/3 of the pituitary masses. Thank you so much for watching this presentation. See you at the next lecture.